everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and we are coming to you live from our studios at ACTN. On tonight's program, we're going to be discussing some common ear, nose, and throat complaints. With me in studio tonight is Dr. Rabindranath Maharaj. Dr. Maharaj is an ENT consultant surgeon based at Gulfview Medical Center in Laramie. As usual tonight, our numbers should come up at the bottom of your screens, and we'll do our very best to get to your questions and comments in the final segment of the program. So guys, let's get the show going. Let's talk ENT medicine, and let's say hello to Dr. Maharaj. Doc, how are you going?
I'm fine, Robin.
Thanks for coming on the program.
My pleasure. I was here, as I was telling you, more than 10 years ago when the program first started.
Welcome back.
So it's nice to be back.
Welcome back, and thanks for coming on again.
My pleasure.
So, Robin, when we were talking about this program, myself and yourself over the weekend, we were saying that, look, you know, it's a massive topic. ENT is a massive topic, and we have 1 hour. So, in order to structure tonight's program, Robin, first of all, in terms of the ears, we would like to talk a little bit about wax.
Yeah.
Because that's a common complaint that will come into me. We'll talk about foreign bodies in the air. We'll talk a little bit about ear infections, which is a common complaint to everyone. Yeah. And then if we're moving down to the nose, we'll talk about rhinitis, allergic rhinitis and regular rhinitis, probably some polyps in the nose as well. And in terms of the throat, I would really like us to discuss tonsillitis, because that's a really common complaint.
Right.
And very importantly, hoarseness.
Yes.
And if we still have time in between that and taking the questions and the comments, I would like you to discuss the common symptoms and signs of head and neck cancers.
Right. So it's a lot, but we will see how much we can get through. Right.
So you ready to go?
That's a rule.
All right. So, Robin, if you could start us off, right? Patients come in, they sometimes complain about hair, like muffled sounds, they're getting pain in the ear, and when we look into the ear, we see wax. So if you could start us off maybe a little bit of anatomy of the ear and tell us how would you approach a patient with wax in the ear?
Right.
Impacted wax.
Yes. So common things are common. In medicine, we always say that. And by far, I think wax is one of the commonest things that I will see as well. As a GP, you will see it.
Of course.
But even as a specialist, they come straight to me as well. And wax is, people ask a lot of questions about wax. You know, what is wax? So that's the first thing people ask. Yeah. So wax is an oily substance that is secreted in the outer canal. If we can look at this, the first slide. Yeah. And so the outer third of the canal is where this oily substance is produced, and it's mixed with dead skin, dust, hair, and so you get wax. So the outer third is where it's produced. Sometimes the wax, when patients come to me, the wax is all the way down to the eardrum, and why that is so is because most of the times people push it down there. So that's the next big thing. How do you clean your ear? Yeah. So, of course, the big thing is Q-tips. Yeah. Right? Everybody uses Q-tips. Yes. And as much as I will preach it day in, day out, it still happens. So the big thing is when your wax is produced in the outer third, and the air is usually self-cleaning. So 80% of people will not have a problem with wax buildup. Right. How the skin grows, it grows from the eardrum out, almost like a conveyor belt, and it pushes out this wax. Right. If we take a Q-tip and we put it into the ear, the shape of a Q-tip is like a battering ram. So the mechanics of it is that it pushes. It can't pull stuff out. So most of the times, the patient will succeed in pushing the wax further in. If you leave it alone, small amounts of wax will come out. We don't notice it because it's small amounts that will drop out. Or sometimes you're chewing, you're talking, you might feel a little flake by your ear, and you realize it's coming out. So when you start interfering, then it starts to go in and build up. So the old adage, don't trouble. That's something to remember with wax. The 20% of people, so as I said, 80% may not have a problem, but there are 20% of people who will build up wax. Yeah. And other than the Q-tip, the other reasons they will build up wax, underlying skin problems. So the commonest one is a dermatitis, atopic dermatitis. Right. You tend to see that in little kids, especially who have a history of allergic rhinitis, which we may touch on later. Yes. Asthma. Yeah. So asthma, atopic dermatitis, and allergic rhinitis may go together. So a lot of kids will come in with that dry skin problem in the ear. They classically get it on the elbows. The pediatrician will tell you on the knees, on the neck. But the ear is a common place for that. And because of that dermatitis, the ear can't clean itself. So a lot of kids end up building up wax because of that.
Right.
So the solution is not just to clean the wax out, but to try to control the dermatitis to prevent buildup. Right. And that is a big one.
Right.
Another one that I see, and it might
That's
be...
a very good point, actually.
Yes.
That's a real pearl there.
Yeah.
Because we have to treat the dermatitis, we have to treat the skin conditions in order to stop the buildup of wax in the ear as well.
Because if you don't treat it, then
it will build up all the time.
Builds up fast.
Right.
So that's an important point to remember. The other one is, besides Q-tips, people who use earbuds a lot. So in the industries, people will use these earplugs for noise, to protect from noise. So that may cause it. Earbuds as well, because everybody is into earbuds, AirPods to listen to music.
Right.
Now, how it causes the buildup, it's not that it touches the wax directly in most cases, I think. I think what happens in those cases, it compresses the column of air sometimes between the wax and the air plug, the noise plug, or the earbud. And that compressed column of air will further push it in. And so they keep they keep fiddling with it, and over time, it builds up wax. So people who wear hearing aids, for example, may have wax buildup because of that too, and they may need regular cleaning of their ears because of the use of hearing aids. Right. So those are some common and important reasons why people build up wax.
Right. So the obvious question, right, the patient would ask is, all right, so I have all this wax in my ears, how do I clean it?
Yes, that's $1 million question. You just banned me from Q-tips. How do I clean my ears? So as I said, most people don't need to clean their ear. Right. But for that 20%, if you build up wax more than normal, the first and simplest thing that you might want to do is use olive oil in the ear. Right. As we said, wax is an oily substance. So you put the olive oil, it softens up the wax. Right. And once it gets soft, and it's a small amount, it will actually run out faster into the outer part of the ear. Right. So when you feel it there, then you may use the Q-tip, not in the ear canal, but more on the outer part to wipe out what is running out. Right. So olive oil is the thing. And again, in Trinidad, people will say, well, which is the best oil? So we typically will say olive oil because it's a light oil, but a lot of us grew up on coconut oil because that's what we have here. Yes. And by all means, I'll tell patients, sure, use the coconut oil if you have it. Most of the time, it doesn't cause a problem. Okay. The other thing that people ask me is what time of the day to use it, because there's an old wives' tale that if you put it in the night, it will get hard and it will clog up your ear further. Right. The reason is if you look at coconut oil in the cooler temperatures in the grocery, you'll see it caking up and it's forming this thick residue. But once you put a drop or two in your ear, the body heat is going to keep that warm. Right. And it doesn't matter in our climate, certainly. Right. So you don't need to warm up the oil as well. That's the other thing. Right. In England and Canada, yes, because the room temperature might be 10 degrees, 15 degrees. In Trinidad, our ambient temperature is about 30 degrees. Let me just ask you, Robin, how much olive oil to put in? So just 2 to 3 drops is all. And that's to help the wax. This is a patient with wax impaction. So this one is prevention. Prevention, right. So if you've gone beyond that into wax impaction now, so they blocked up, they normally build a lot of wax. So in a case like that now, we need to soften the wax for it to come out. Right. And so you may want to put more than 3 drops. You can't overdose on the oil, so I would tell patients use 3, 4, 5 drops, because you put a drop, it runs out, put more. Fill up the ear canal. Right. And you could do it in both ears. And you could do it in both ears, but little things over years of doing this, I will tell you, that will help a lot of the GPs as well. Yes. When you start to put the oil, you need to warn the patient that the air is going to feel more clogged up, because the oil is going to soak into the wax. And it's going to swell up like a sponge, and it's going to block up more. So sometimes patients panic and they say, well, this thing is making my air worse. Yes. Right? So you need to tell them up front, okay, you're going to put oil for this impacted wax to soften it. Initially, it might feel worse for the first few days before it gets better. However, if it does not clear up by the end of the week with the oil, and you're using it every day in this case now, then you need to go back to your doctor so that they can now clean it out.
Right.
Right?
Right, so that's olive oil, right? Now, in Trinidad, you well know as well, on the pharmacy shelves, they have different wax removers, right?
Yeah.
I think, I'm not going to call any of the brands,
No.
but they were very popular and people use them.
Yeah.
Is that definitely a no-no?
Not necessarily.
right.
They have the rules.
Because Trinidadians everybody have home remedies that they put in the air besides olive oil.
Yeah, there are lots of things.
People might put peroxide, people might put different stuff.
And we use peroxide in the past. A lot of the drops may still have peroxide in it.
Right.
I don't like the peroxide too much because if the air is already inflamed, it tends to irritate it further.
More.
And that's the other thing with some of the over-the-counter pharmacy wax softeners. They are organic solvents. So if you were to look at some of them, the contents, you will see oil of turpentine.
Exactly.
So you are literally throwing turpentine down your air. And if you have an inflamed air canal, it's going to get worse and the patient is going to come back with more pain.
Right.
So that's where the olive oil is gentle and it will not do that.
Right.
But there are some newer products now that are basically
olive oil.
But they market it as medical grade olive oil.
Medical grade olive oil.
Right? It's the same olive oil that you have in your kitchen.
They just paid more for it.
You pay more for it.
All right, so we're using the olive oil. It's filled up with olive oil. The patient's doing that. The air still feels funny. The wax is impacted. They come to you. What do you do next?
Right. So the classic thing is, Doc, I come to flush out my air.
Syringe out my air.
Right? Syringe out my air. And that is still a good method. It's not that it's a bad method. Everything has a place.
Right.
So it's an older method, and I still use it for specific patients.
Right.
Once there's no infection in the air, once the wax is soft and not very hard, once you can see the eardrum, or you know this patient from before without any damage to the eardrum.
Or infections in the air.
Because if you have these things, you cannot syringe that air.
Right.
So the other method that we use would be the suctioning, which is a safer method if there's infection or so in the air.
Right.
So that's basically a little vacuum pulling out the wax.
You have a slide on that, I think?
No. Actually, I don't have the slide.
You have any slides on the wax?
Well, we have the slide on the wax. So if you look at the picture, so that's the ear canal you're looking at there. And that's just a big ball of wax blocking the eardrum. Wax is not supposed to be that amount in the ear canal. You're supposed to see the eardrum and probably just a little sprinkling of wax. That next picture you're seeing on the slide is foreign bodies. So the one on the right of the screen is a Q-tip. So that's one of the problems of people using Q-tips in the ear. The Q-tip gets stuck and they end up by you and me to take it out. Right? So Q-tips, besides impacting wax, can get stuck in the ear.
Do you also suction those out?
I actually use an instrument called an alligator forceps, which is a micro forceps to pull it out. It's an easier way because if you try to suction, sometimes it doesn't pull it as easily. Because a lot of times patients will put oil in the air when they figure it's stuck there. And the problem is now the Q-tip soaks up the oil and swells up more. So don't put oil in the air if your Q-tip gets stuck. We need to take it out if you can't reach it with a forceps.
So what sort of foreign bodies would you? I mean, I can give all the patients actually, Doc, what kind of foreign bodies you see in the air?
If you look at the screen now, you'll see one of them, insects. So
is that common?
It's not that common. Right? It's not that common, but I'll tell you over the years the different things I've put.
And that's probably really painful for the patient, Is it?
Some of them. So one of them that I remember very distinctly was a cockroach getting stuck in the ear canal.
Wow.
And the reason insects get stuck there is because your ear canal is a dark, warm environment. So insects may get attracted to it. They go in and then realize it's a dead end and they can't get back out. And they get stuck. So the cockroach, this cockroach was stuck there. And if you look at a cockroach's legs, it has barbs on it. And this thing was creeping against the patient's eardrum. Big man. And big man coming all in pain. So that one I remember very distinctly. And I've had a few others. Wasps. I've had maggots. Maggots tend to come in patients who are underlying issues with like strokes or patients who have mental issues. So flies may sit and lay eggs there.
And how would you get these things?
So if you're at home and you feel this is a mosquito buzzing in your ear and you slap your ear and you push him inside and he stays there and he's dead now.
What would you tell?
Or he's alive. Let's say he's alive still. The first thing you do is you fill your air with olive oil again. We come back to that wonderful concoction of olive oil. What you're trying to do is drown the insect so that it stops moving. Right? So because
less movement, less pain.
Less pain, correct. So you put that olive oil in there, it drown them, and it stops the movement and the pain.
Yeah.
And if it's a small insect like we saw on the screen there, it may actually float out with the oil.
Right.
If it's a bigger insect, like a moth or so, it may swell up more and get stuck.
Yeah.
But then, of course, once it's dead now, you have the luxury of taking your time to go to the doctor. If it happened in the late night, you can safely wait till the next morning and
go into the emergency room or the doctor.
Yeah, you don't need to rush to go to the emergency room. Once you know it's not moving and you're not hearing movement, you leave the oil there and you go to the room, the doctor in the morning.
All right. So when they come into you now, how do you get it out with the suction? Or?
Well, again, it depends on the state of the insect. You might suction it out in parts if it's broken up. Or again, we have all these special instruments, microforceps, that we can use to pull them out.
Right.
Now that works well for adults, but imagine a 3-year-old child coming with that. We may not be able to do it in the office. We may have to take them in theater with a short general anesthetic and do it with the microscope. So that's the safer way.
All right. I want to jump, right?
Yeah, let's
get a question out of left field, right?
Yeah.
Before we go into the infection. You're talking about foreign objects being stuck in the air. What foreign objects being stuck in the nose?
Another common one. My mother...
So let's say, sometimes you get these calls, 3-year-old kid or 4-year-old kid stick something up their nose, like a little bead or a little some fat toy, and the parents are panicked. The thing is in the nose. What do we do?
Yeah. So foreign bodies in the air and the nose common in children because children love to, it's curiosity, and they love to stick things in these orifices, the nose and the ears. My mother told me, I think I stuck a pea in my ear, in my nose when I was small. Right? So peas, anything that's small, beads, little batteries, silver batteries, they will stick that in. Tissue, cotton, all sorts of.
And then they'll tell the mom and dad, I stick this in my nose and watch it.
Right. So they will tell them. So it's good when they tell them. When they don't tell them, then the problem could start too, because what happens is 3 days later, the parents notices this child has a foul-smelling discharge from one nostril. And that's a key thing, one-sided. If you see a discharge on both sides, it's usually not a foreign body. If you see a child coming with a foul-smelling discharge in one nostril, 90% of the time, it's a foreign body stuck in there.
Right.
So they come in with this, parents saw it.
Let me take sorry to interrupt you. Before they reach to you, could they do anything at home?
Right.
Yeah.
So it happens if they stick something and it's not too far in, you might ask the parent to block one nostril and get the child, if they're old enough to blow, if they understand the concept of blowing the nose, keep the mouth closed and blow the nostril.
Right.
So you're hoping now the force will do it. Because I've seen a few patients where the parents on their own worked it out like that.
Right.
And the child was able to blow out the bead or the small foreign object. So that's the first thing you can try to do at home. You block there and you get them to blow. If it's a 1-year-old, you can't get them to do that.
Right.
So you may want to see if it's right at the edge, and this is where it gets a little dicey, because if it's right at the edge, you might be able to use a tweezer and pull it out. It depends on the type of object as well, because if it's a bead and you use a tweezer and you hold it, it slips and it goes further back. If it's a piece of paper, tissue paper or cotton, it will hold on nicely and you'll be able to get it out. So you have 1 or 2 attempts at most at home.
And that's it.
And that's it, because after that, the child is going to get restless, and all you're going to do is push it further back and traumatize the child. So stop. Stop there, take your child to your doctor. Now, I'm going to, normally, I like my GPs to do things, but in children, I'm a little anxious when it comes to little children. Especially with the air foreign bodies, because it looks like it's right there, and they try to take it out and they push it further in. So parents try to push it further.
And that might even result in a surgery if it goes too deep.
Well, sometimes it can rupture through the eardrum. The foreign body could go through the eardrum, which is another set of problems. So you try your first attempt or second attempt. If it's not happening and the child is restless, stop. And I would prefer children to go to your ENT specialist.
That's fine.
Adults, you may have more leeway with them. But children, let them go to the ENTs. And we may be able to get, there are lots of them we can take out in the office.
And you have more instruments available.
We have more instruments. We have, a better way to handle it in the office. So it's not that we have to take every child in theater. Also, in fact, most of them I will take out in the office.
All right, cool. So, Robin, we need to take a little break at this point in time. So, guys, we're going to take a little break, a 1-minute break. We have Dr. Rabindranath Maharaj here with us. He's an ENT consultant surgeon based out of Gulfview. Please send in your questions, your messages, your comments to us, and we'll address it in the final segment of the show. So, guys, we're going to take a quick break, let Robin collect his thoughts, and when we come back, we're going to move on to ear infections and a bit of sinusitis.
Yes. Yeah, we could.
101 is on every Tuesday and Thursday night at 9 p.m.
I'm your host, Joshua DeMatos, and I'm joined by Nikolai Madry, Jeremy Bridgenath, and David Lucky.
This is where you'll get all the football news that you need to know.
Glamorize football to what it is. This viewership speaks for itself at the end of the day. These guys are making billions on viewership.
With heated banter.
They'll have more trophies, more Premier League trophies, more
You are talking past. You are talking past. I'm talking about current situation of the club.
And trending discussions.
Barcelona was built around Messi.
Well, Messi created the most chances against Real Madrid in the Champions League.
Covering all the major leagues.
If you all don't win Europa, you can hold this. This is the only cup you all are going to hold.
Failure to support their core coaches with the kind of budget.
I think you have somebody delivering some food for you. We need to get service like this on the show.
Yeah, I can do some of that right now. It's about that time.
Football 101, bringing the field to your home.
You have the most assists right now.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back. We're here with Dr. Rabindranath Maharaj, and we're talking about ear, nose, and throat, common problems. Please send in your questions and comments, and we will get to it and we'll address it in a little while. So, Robin, we just finished talking about foreign bodies in the ear, wax, foreign bodies in the nose. Let's get straight into ear infections. Painful. Patients come in, they get a lot of pain. You have a look, you've probably seen it red. Take it from there. Let's describe the ear infections, the different type of infections, and how we approach it.
Right. So in the first slide, we had the anatomy of the ear. So usually we divide the ear into an outer part, a middle part, and an inner part. So most of the ear infections we will see would be actually outer and middle ear infections. So let's start with the outer ear infection. So that is basically any infection that starts on the outer part of the pinna, that's the piece outside, straight down to the eardrum. So that's the outer ear infections, and then behind the eardrum is the middle ear, and then deeper inside is the inner ear.
Right.
So the outer ear infections usually come about for two main reasons. Water getting into the ear, and scratching the ear. And usually it's a combination of both.
Right.
So what will happen is patients will go to the beach, they will go in the water, the water gets in, the moisture stays there, they take a towel, they dry it, or they use a Q-tip to dry it, they abrade the skin, bacteria enters now.
Right.
And so they get an outer ear infection. What happens, it swells up, the canal swells up, and if there's wax in there, well, it's even more pain because of the pressure.
Right.
Outer ear infections generally are extremely painful if there's wax impaction with the infection.
Of course.
I've had, in fact, more than 5 or 6 women told me that it was worse than the labor pain.
Wow.
So it can get as severe as that.
Right.
And usually the painkillers you need to give patients, most of the times I have to combine painkillers. So Panadol ain't going to cut it alone. Usually I will combine like Panadol and Cataflam or Olfen or Panadine. So it's a combination because you need to control that pain.
Yes.
And then, of course, with the swelling, you will get blockage as well, the hearing drops. So those cases, we need to see them to treat. And usually topical drops, antibiotic drops, as well as cleaning the ear and good pain relief is all you need for most of them.
All right.
You do have 1 or 2 exceptions that could be more serious. As I said, they're very painful, but most of the times they're not life-threatening. Some patients who are diabetic or immunocompromised, like HIV patients, chemotherapy patients, they can have a condition called malignant otitis externa, where the outer ear infection could actually spread along the bone and up to the brain, and it could be life-threatening. So those I take more seriously, and I prefer to see the diabetics with ear infections.
Yes,
The family doctor can handle most outer ear, simple one, but if there's a diabetic involved, a chemotherapy patient, I want to see them, or another ENT should see them.
Okay.
You need to be much more aggressive with those.
Okay.
The middle ear infections, the cause for that usually is if there's a throat infection, a nasal blockage from sinus problems. It blocks the connection between the nose and the ear, and you end up with an infection behind the eardrum. And sometimes you get fluid building up behind the eardrum. And then the patient will start to, so the typical history is the patient will tell you, okay, first they had a sore throat or stuffy nose. A few days later, the ear starts to hurt them. And then the pain gets very intense. It builds up to a crescendo, and then they start to get a discharge.
Right.
As the discharge comes, the pain starts to go.
Right.
Because the fluid has now reached this point where it's built up enough pressure to rupture through the drum.
Right.
And so the pressure is relieved. That's nature's way of relieving the pressure, as I tell them.
Yeah.
So the pain goes, or most of it goes, and they get this discharge. The infection is not gone yet, so they need to know that. We still need to see them.
Right.
So that's the history.
That's a very important point. Because the pain is gone does not mean that the infection is gone at all.
Correct.
It needs to be seen by a doctor.
Yeah, and those will not settle with just drops. So, you know, you go to your pharmacist, and they're trying to be helpful, and might give you some drops and say, take the drops and see. Once you see you had a sore throat and you get intense pain and then a liquidy discharge, outer ear infections don't give you much of a liquidy discharge. If you get a liquidy discharge, it's usually from a middle ear infection.
And it obviously smells really foul. And sometimes it smells foul.
Yeah, sometimes it may not even smell foul. And those need oral antibiotics. So we need to see those, or you need to see those to treat them.
All right. And those are basically the gauntlet of the infections?
Yeah, so those are the two main ones. The inner ear infections now. So those don't present with pain. Those present with either hearing loss alone or severe dizziness or vertigo.
And how do those patients get those infections?
The commonest causes are viral cause. So patients get the common cold, they get any virus, COVID, any other virus, and then they will, sometimes a week beyond the virus, they will get this intense spinning or vertigo, as we call it. And they may start to vomit, and they may have a problem with the hearing dropping as well. And they have no pain. So that's a big differentiating factor. They have no pain with it. And so those are inner ear infections, and we need to see them to treat those.
And when you examine the ear, what do you see?
So that's it. Because it's inner ear, you can't see down to the inner ear. You can see the outer ear, you can see the eardrum, you can see a little bit through the eardrum into the middle ear. So usually we will have to look to make sure it's not one of those as well. But once we look and those things look normal, and that history that we get, they had a virus, they got intense vertigo, the hearing dropping, it's usually a viral infection. And viral infections don't need antibiotics. So patients will come and say, well, doc, I think I have an infection, I need some antibiotics. No, you don't. They run their course, so we put them on medications to help the vertigo.
The symptoms.
Semetil, Stugeron, and those will settle them, and then we will usually give them time off for that week, and most patients will settle down.
So I think what I'm getting from you in terms of ear infections, yes, patients have pain, everybody know that they have, but what I'm getting for you is that from you is that it's something that needs to be evaluated, something that needs to be checked. Because people can't just really go to the pharmacist and say, look, I get ear pain, because the purpose of a doctor or anyone, you have to examine, you have to look. And treating things blindly could sometimes be dangerous.
It can. With this pandemic, we try the online consultations, and for some cases it might work. But for ENT, I'll tell you,
you have to get your hands on the patients.
It's very difficult to do online consultations. Yes, the history helped me, but there's always that little doubt in the back of my mind. Am I missing something because I didn't look?
So you're hearing it, guys, from the doctor himself, the ENT specialist. He wants to look in the ears. We can't just do that. So let's move on, Robin. Let's move towards the nose. Right. So we've completed the ear. We moved to the nose. I suppose the major two complaints that you would see in your office as well is rhinitis. Major complaint. And sinusitis.
Right. So a lot of times patients will come and they will say, well, doc, I have sinuses. So we need to understand what is sinusitis and what is sinuses. And well, rhinitis as well.
I think you have a slide in the anatomy.
There's a slide, about the anatomy. So if you could pull up that slide, let me see what that would be. Number 8. Slide number 8.
Josh.
So your sinuses are these air-filled spaces in the bones of your skull. So you'll see them on your cheeks on the diagram, and then you see them over on your forehead above your eyes, and then actually between your eyes you have some smaller ones as well. So those are your sinuses, and they all drain into your nose. So the correct terminology actually for most patients is not a sinusitis alone or a rhinitis, but a rhinosinusitis, because they're all connected, and usually it's not one alone that is involved. So most patients will have a rhinitis with a bit of a sinusitis. What may distinguish specifically where the bigger problem would be the symptoms. So patients will come, the two biggest group of rhinitis patients are what we call allergic rhinitis and non-allergic rhinitis. Those are huge topics. I will just try to brush on it briefly. But when the nose is acting up with these conditions, then it will block the drainage of the sinuses into the nose, and then you might get a sinus problem as well. So in Trinidad, patients will come and say, "Doc, I have a head cold." Right, so we need to understand now what is a head cold. And a head cold basically is a sinus infection. Right. So what the patients will perceive will be mucus dripping in the back of the throat. It seems to be coming from the head. It's draining down there. Where it's really coming from is the sinuses, which is at the base of the skull, and as you saw in the picture, on your cheeks. And that mucus now drains into your nose and into the back of your throat. So you feel this cold coming from the head. Right. So a head cold, I would say, is the local terminology, but it means the same thing as a sinusitis most of the times. And you will get the pressure and the pain over the relevant sinuses. So if it's on your cheeks, those sinuses, patients will have pains on their cheeks. They may get pain in the upper teeth as well. So a lot of times they go to their dentist thinking they have a cavity, and the dentist will say, "Well, your teeth are fine." You have to think sinusitis as a possible cause. They may get a lot of headaches in the front here. And those could be from sinus problems other than the normal tension headaches. So a sinus part, when the sinuses are involved, you get those areas of the face being involved. It's mainly the nose. You may not get those symptoms. So you might just get sneezing, itchy eyes, scratchy throat, runny nose with allergic rhinitis. Non-allergic rhinitis can give you some of those symptoms too, but it tends to come more with more stuffiness, more nasal obstruction. You can't
when you say non-allergic, what do you mean? Like a bacterial infection?
So the classic allergic case would be an allergic reaction to things like pollen, dust mites, pets, moles.
And that's the typical runny nose, itchy eyes type symptoms that we see.
Sahara dust is a big one, because when they analyze Sahara dust, they realize besides the sand from the Sahara, there's actually moles in the Sahara dust. They have dust mites in it as well. So it has everything, right? And there's some pollen as well. So Sahara dust can affect a lot of patients, not just from the irritant point of view, but for the allergic patient, it's a big problem. So that's the allergic group. And then you have the big non-allergic group. So they have a sensitivity in the nose, but not to the factors we mentioned before, like pets and pollen. And this group could actually have a much wider range of sensitivities. They may react more to temperature change, humidity change, stress. So patients, when they stress out, they block up or their nose run. Some patients have a rhinitis when they eat. Their nose starts to run. Of course, an infective rhinitis would be like a common cold. So that's a form of rhinitis. Medications. A lot of patients on high blood pressure medications, they get nasal blockage. So it's important to know in the older patient what medications they're taking. Aspirin can do it in some people as well. So medications can do it. Hormonal changes can do it. A woman in pregnancy, their nose will block up a lot. If they had a tendency before, it will get worse in pregnancy. Patients on the pill, the contraceptive pill, may have nasal symptoms. Patients with thyroid problems may have nasal symptoms. So, a lot of times we box medicine into specific areas.
What I'm getting from you is a real gauntlet of possible triggers.
Correct.
And I must confess, I didn't realize it was such a wide
and that's why I love ENT. People ask me, why do you like it? Why did you choose ENT? And I tell them, I say, one morning I can get up and be an ENT medical doctor where I have to do internal medicine diagnoses. And the next morning I can get up and be a surgeon. And I can operate. So I get the best of all worlds. So that's why I like ENT.
Except it's limited to above the neck.
Well, I'll tell you, head and neck anatomy is one of, if you remember from medical school, is one of the most technical anatomies. So it's quite a challenge. So for me, I enjoyed it.
Right.
So rhinitis, that non-allergic group could be a huge group, and your history is a big part.
Right. So that's the history. Now, I'm bringing it down back to the patient, right? The first thing that the patient says, they're fed up. Rhinitis is a real chronic kind of thing. It's going on. They don't know what to do. They're going from doctor to doctor. They're reading up everything on the internet, and it's not going away. Nothing they could do. How would you advise patients to control their allergic rhinitis symptoms? What could be done?
Right.
Does any investigation need to be done?
So most patients with mild allergic rhinitis, patients eventually, I want them to be the masters of their condition, meaning that they need to understand their condition and understand what they can take for it. And what most mild cases, they can manage at home. If it gets a little worse, they can go to their family doctor and they can manage the other sets. So the classic things we will tell patients when they have allergic rhinitis, let's say, is there are two strategies I will employ. One is medication to control and stabilize the nasal mucosa and the lining.
Which is?
So you have the oral medications, the tablets. So you have like what we call them the antihistamines. So they will dampen the allergic response. And then you have the topical sprays as well, which will help to directly into the nose to reduce that sensitivity and that reaction. So it's usually a combination for most patients of an antihistamine tablet and a nasal spray. And then the other big one that has gained popularity a lot is we call it a sinus rinse, or a nasal wash. So that's basically like a salt solution to rinse out the nose, thin out the mucus, clean out the area.
Which people go to the beach and do.
So that in the past we say go and take a sea bath, but it was blocked up. We had COVID, so we couldn't go to the beach. So now we have to go to the pharmacy to get the beach, right?
So it is therapeutic, right? Going to the beach and using this, right?
It is. It does help. So it does help to clean out the area a little more. And but an important thing I tell patients is, because patients will ask, how long do I take these medications for? And that's an important question to answer, because there's no tablet, no spray, no medication. I will tell you, take it for a week, take it for a month. Your problem is going to go away and it will never come back. No, it doesn't work like that. You stabilize with your medications, and then you try to understand your triggers and you try to avoid it. Right? So that's the long-term strategy. So if you can, let's say well, I have a cat at home and I play with this cat and this dog and I'm reacting. Well, unfortunately, that cat or dog has to go. Or if you have a lot of stuffed toys in the bed and carpets in your house and you're reacting, those things will have to change. There's no point in taking medications and you're exposed to these things.
And
it up in mud.
It is a real task in patience, isn't it?
So it's a lot of detective work. That's where patients have to understand. So I wouldn't even say it's purely trial and error. It's detective work. So you go, and how you do the detective work is, most people with the allergic response, it will come on after exposure from as early as 15 to 20 minutes or up to 2 hours after. So by using a time frame like 2 hours and you retrace your steps, you will then see, okay, this is the environment I was in. And so you start to home in on your environment. If you wake up this morning sneezing and scratching eyes, and you played with a dog yesterday morning, chances are it wasn't the dog. It was something in your room, probably a stuffed toy, a pillow with dust mites.
Detective work.
So detective work helps. Now, you asked about investigations, and sometimes we can do tests as well. So we can do allergy testing for some patients. There are two ways we can do it: a blood test and a skin prick test, where we you put little bits of the different things on the skin and see the reaction. That one is actually done by an allergist who is a specialist for that area. They actually do that test. The blood test, some of the labs in Trinidad do it. And so it's an easier one to consider. They're not 100% accurate, but they help us a lot. So I still employ it as well. And then the other thing that for the difficult cases, let's say you are treating them or the patient is treating themselves and they're not settling, well, then they come to me or another ENT, because now we need to examine that nose properly. And if we do a procedure called a nasal endoscopy.
Yeah,
so
you have a slide there with that.
Yeah, so that,
Josh?
the slide, slide 13, I think it is. So that scope that we use, it's like a big long telescope. So when I pull out that in the office, patients, the eyes open big and they look at me incredulously. Where's that going? I say, well, so now I have a good analogy for a lot of patients. I say, have you ever had a COVID swab?
Yeah.
So it's like a COVID swab, except it's usually less uncomfortable.
Right.
Because with the COVID swab, usually you have to swirl that swab around, whereas with this, I can simply pass it. And I can see further back into your nose. I can see if things were missed just by looking with a normal light.
Right.
So it's a procedure we do. Sometimes we use a topical anesthetic, but most patients can do it without. It's just a 10-second procedure, so it's not a big procedure at all. All right. So that's something we may have to do.
All right. So I suppose basically what you're saying there, Robin, is the allergic rhinitis or non-allergic rhinitis. The main onus of investigation or find out what is happening is on the patient with their history, looking at their lifestyle, looking at what is their triggers to try and avoid. And the hallmark treatment is the antihistamines and the nasal spray.
Yeah.
And for those patients that are a little bit more tricky, you're going to take a look inside the nose to
because sometimes there may be other problems in there, polyps. There could be a deviated septum. There could be bad infections, and some of them may not respond to medications. We may even have to do surgical interventions for some of them.
All right, so Robin, it's another convenient time for a break.
Okay.
We're flying through it.
Yeah.
Guys, so we're going to take another break, and we'll be back in one moment. And please send in your questions or your comments, and Dr. Maharaj will address it in the final segment.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Rabindranath Maharaj, and we're doing some ENT discussion. So we did the ear, we went through some topics in the nose, allergic rhinitis and non-allergic rhinitis. At this point in time, Josh, I think you have a few questions for Dr. Maharaj. If you could start with perhaps one, and then we move on to the throat. So Josh, you could start up with the first question. When I'm taking a shower, water frequently gets into the air, and I usually hear an echo. Can water do any permanent damage to the air by this happening?
So, no. It shouldn't do any permanent damage. But if the water gets into the air and it doesn't clear up within the next hour or so, I would say.
Yeah.
What that might imply is you might have some buildup in your ear already. You might have some wax in there already. So the water now is being held by the wax. It's soaking it up and it's not being released. So that's a clue sometimes that patients will tell me, Doctor, water gets in, I go to the beach, I go in the water, and when I come out, my ears block up now for the next few days.
Yeah.
So water will not stay so long in your ear.
So it's obviously something else like the wax.
Something else is there. Usually it's wax and it holds on to the water. It's soaked up.
And gives you that feeling of clogging.
Fullness and clogging. And so that means it needs to come out. So you could start with the olive oil to try to soften and let it run out. But if it's not going away, as I said, over a few days, we will then need to see you to clean it out. So that's important. So it's not serious. And if you think that water is getting in and it's bothering you a lot every time you come out, the simple things you can do, if you're not washing your hair, wear a shower cap. If you have to wash your hair at that point, you can use a piece of cotton, not a cotton cotton swab, just a piece of cotton ball. You put it in by the ear, and you can take a little Vaseline and paste it over the cotton. What you're doing is you're sealing it and you're waterproofing the cotton. Because cotton is porous, so it will absorb water. So a lot of people know about putting the cotton, but they forget about the Vaseline part. I mean, if it's not a big problem, you don't have to do all of that. But people who have ear infections, I make them do that because we cannot allow water to get in an infected ear. It will get worse.
All right. So that's put a piece of cotton, put the Vaseline over the cotton.
Over the cotton.
That's to form a watertight seal.
Yes, it's like using an earplug. So people say, well, I could use an earplug. Yes, you can. You have to know what type of earplugs to use. You have two types. You have acoustic, which is for sound. So that one is not waterproof. And you have aquatic, which is for water. So those are usually silicone based. So you can use those. Thing about this using those is you have to clean them every time, and they're a little harder. Whereas cotton is soft and it's cheap. You're discarding it and using a new one every time.
Okay, makes sense. Josh, go ahead and put up our next question there. Hi, good night, docs. Great show. Keep it up. One question. If I move my lower jaw to the right, my ear gets clogged. Also, if I lay on my left side, my left ear gets clogged. What can cause this? I feel no pain. Just it's clogged to the extent where I can't hear anything through that ear.
Okay, so sometimes if there's a bit of wax in there, but it's not a lot, it may not be enough to block up the whole ear canal. But sometimes the position of your head, it may roll around a little bit. Sometimes if you move your jaw joint is actually right in front of your ear canal. So sometimes by moving the jaw joint, it may shift a little bit as well, and that may cause the wax to shift. So those are two possibilities. There's another thing that can give you a feeling of fullness, not a true clogging or decreased hearing, but a feeling of fullness in your ear. And that is a condition called Tmj Dysfunction, where the jaw joint actually gives you problems. Patients who grind their teeth at night when they're sleeping, who clench a lot, they tense up the muscles around the jaw joint. And when they do that, they get this feeling of fullness as part of the problem. They may even get pain. They may get a clicking sometimes in the ear. So that's where it's important for us to examine the ear to understand if it's due to wax, if it's due to something like a TMJ problem. None of them are really very serious, but I mean, if it's lingering, my advice would be, get it looked at.
All right. So, Doc, I just want to go into a bit of the throat stuff. Most importantly for me tonight, hoarseness of the throat. That's a very common symptom that comes into general practice. How would you advise us as patients, as doctors, as a community, to treat with hoarseness? I'm trying to educate my patients so it's not something that you ignore.
No.
What do our patients do when they have a hoarseness in the voice?
So hoarseness can range from the very mild problem to the very severe problem. So it goes through the whole spectrum. Hoarseness. Now, when we say hoarseness, it's a broad term. I mean, we usually mean this raspy voice. But a lot of times, alteration in voice is sometimes referred to as hoarseness. Right? So sometimes the term hoarseness may not encompass all the changes in voice. And different types of voice changes may imply different problems. So starting with the mild, the commonest things that will cause hoarseness, a viral infection again. So we call it an acute laryngitis. So patients get a cold, and within a few days the voice gets raspy and they go hoarse, they lose their voice, and a lot of times it's not painful. So they don't have to take plenty painkillers, and most of these simple ones will go away within a week or so. The other one is excessive voice use as well. So my big group of patients with chronic voice problems that are not very life-threatening are teachers, preachers, singers, and politicians.
We have some good examples right now.
Because they have to use the voice a lot. They have to talk plenty. Or maybe they talk too much.
And shout too much.
Maybe they talk too much, they shout too much. Right? So once you have to use your voice a lot, the vocal cords, if you get some of the slides, we could probably appreciate it a little more. So let's look at slide, what number is this? 17.
Slide 17, Josh, not that one.
That's the tonsil.
Right.
So slide 17, on the left you will see what the vocal cords look like, an upside down V. The front of your throat being to the top part of the screen and the back of the throat being the lower part. So those two white things there are your vocal cords, and they're supposed to look white.
Yeah.
When you get a viral infection, you get an acute inflammation of the vocal cords, they get red. So if you look at the one on the right side, you'll see the cords not as white, they're slightly red.
Yeah.
So that's usually the picture you'll see with an acute laryngitis.
Right.
Now that's not something that the family doctor will see in the office. They can't see down there.
Yeah.
In fact, that's where we come in to look in some cases. Now we don't need to look at every patient who has hoarseness if it's for a few days. So some key points, the duration of the hoarseness is crucial. Most simple cases of laryngitis or inflammation of the cords might go away within a week or two. So if you see a patient with hoarseness and they had an obvious virus, they simply need to rest their voice. They don't need antibiotics again for most because it's a viral infection. Simply resting the voice will help it because every time you speak, every time you cough, the cords, they hit each other, they bang against each other. So the more you speak, the more it gets irritated. So you simply resting the voice helps a lot.
Yeah. Can't tell a politician to do that.
Can't tell a politician that. Some women might find it hard. That's been bad. Some men might find it hard too. Right? These days, some men, they talk, so politicians. But I have the whole gamut of patients, politicians, preachers, singers.
Yeah. So they need to rest their voice.
They need to rest the voice. So most simple cases, resting the voice is important.
Right.
Steam inhalations, quite useful.
Okay.
So hot bowl of water, covered with a towel, and the purpose is just to channel the steam, right? You don't need any menthol crystals in there or any added ingredients.
Right.
Pure steam, because warm, moist air is the best thing for your throat.
Right.
And you can go in the shower as well. You steam up the bathroom with the hot water, and you breathe in the steam. So that soothes the vocal cords and it helps it.
Right.
Very cold air conditioned rooms will dry out your cords. So if you sleep in a cold air conditioned room, you're working in a cold air conditioned office, it could make it worse.
Right.
Inhale irritants.
Right.
So that basically means people who are around a lot of smoke, people who use a lot of chemicals, people who use bug sprays, cleaning agents, strong perfumes. All of those things are going to irritate the vocal cords. So you need to avoid those things extra for that week or so.
Okay.
Simple advice, but they go a long way. Better than any antibiotic will be needed or any other tablets or so.
Right. Right.
So that's the simple ones.
Yeah.
But then you will have some cases of hoarseness that will go on.
Yeah.
So 2 weeks pass, patient's still hoarse. And once you start to cross that 2-week, 3-week period, something more might be going on. And that's where, as a family doctor, if you see a patient with that duration, send them to the ENTs to have a look.
And what would you do?
Right. So when they come to us to see the cords, we need to use a special instrument. So if we go to slide 16, we will see a procedure that I'm doing on a patient there, with his permission, of course.
Right.
He allowed me to put the slide up. And so we pass that scope. That's it's called a flexible laryngoscope, and we pass it. Traditionally, we go into the nose and into the throat in the office. So it's not a big, painful procedure. Again, sometimes some patients might need a topical spray anesthetic to help along, but there's some patients who prefer it without. And sometimes I might just go in through the mouth and bypass the nose for some patients too, and they prefer that.
Right.
But with that instrument, we can go down, and the view that you saw in the earlier slide, that's the view we get. So we can see the vocal cords, and we can tell if this is just simple inflammation or if there are additional things going on. And if you look at some of the other slides, you can see some of the other things that we might see. So like slide 18. If we go to slide 18.
And then after this slide, we'll just take one or two other questions, right?
Right.
Slide 18.
So slide 18, you see vocal cord nodules.
Yeah.
You see 2 red circles, and those are over the nodules on the cords.
Right.
And those are like calluses on the cords from excessive voice use, prolonged voice use. So again, the singers, they actually call them singers nodules as well, and for good reason. Lots of singers have suffered with this in the past. In fact, when I was looking it up, Pavarotti had vocal cord nodules.
Right.
Whitney Houston had vocal cord nodules.
Okay.
Julie Andrews had vocal cord nodules.
Okay.
So there are lots of people, Justin Timberlake as well, yeah. Right. So a lot of people, it's a hazard of their job.
Right.
And so we need sometimes to, besides simple treatments, we may even have to go in with microsurgery to remove those nodules to help them.
All right, Josh, let's get some of the messages coming in. Hi, good night, Dr. Maharaj. Great show so far. May I ask, what would be the most common cause of nosebleeds in children?
Right, so nosebleeds are another common one.
Right.
And children, it's actually very common.
Yeah.
Reason for that, the front of the nose, the partition between both nostrils is called the nasal septum.
Yeah.
And that, the front of that septum, so that would be basically here and here on either side. It's filled with a lot of blood vessels, small blood vessels. And those blood vessels, they bruise easily.
Right.
So the commonest, and I call it the garden variety nasal bleeds, because you do have a few nasal bleed conditions that could be more serious, but the common ones are right in the front there. And the reason children come with the bleeds, a lot of them actually have a form of rhinitis. Allergic rhinitis is one of the common underlying causes. So again, it's not just treating one symptom. That's the beauty of medicine. You need to tie it in to a bigger picture.
Yeah,
the bigger picture here, a lot of patients, when I question them, the children may have allergic rhinitis. So what is happening? They're sneezing all the time. They're rubbing the nose all the time. So what they're doing is they're bruising the vessels and they're bleeding.
Right.
So yes, that's one of the commonest causes. Another common one, well, the common cold. It's an infective rhinitis, so the vessels, they dilate more, and so they bruise more easily, because patients now, they blow their nose to clear the cold, and they bruise the vessels.
All right. So, Robin, I'm just pushing you a little harder now.
Yeah, I know. We have a lot. So
let's get our next message. Josh, what is the best way to fight off the Sahara dust?
Well, I don't think Sahara dust is going to finish. No. It's an endless supply. So
it's gotten worse?
I don't know.
Because in the past, I could tell patients about the Sahara dust, and they're watching like, what Sahara dust you talking about, Robin? Yeah. And then now they're like, I'm seeing the Sahara dust.
Yeah, I'm not sure. Yeah. I mean, I think we're more aware of it.
Yeah.
But this thing has been going on for eons, I think. I mean, that's a natural.
So I think in your field, more than any other field, right, the ENT field, I think you see the effect of environmental pollution and the effect of destruction of the environment more than anybody else.
Yeah, because people who are around Point Lisa's area as well, they have a lot of nasal symptoms. But coming back to the Sahara dust, so you can't avoid the Sahara dust if you go outside. So the simplest thing would be listen to your weather news. And try to know when we're going to have big plumes. Like right now, we are having a big plume coming across since yesterday, and it's going to go for the rest of the week. So understanding when it's coming, and that's why your weatherman and weatherwoman will be very useful for you.
All right.
If you know that is happening, you may then opt to do most of your work indoors if possible.
Right.
So, you don't go outside and play football in the evening every day for that week.
Maybe wear the mask as well.
Right. Well, wearing the mask is useful now, because a lot of people will filter it out. So it's actually useful not just for COVID, but also for the Sahara dust.
Right.
So wearing the mask is good. I mean, before COVID, you would have looked really weird walking around with a mask for Sahara dust. Right. So wearing the mask, but try to do more indoor things during that time.
Right.
And if you suffer from nasal problems like allergic rhinitis or non-allergic rhinitis, and in the past it tends to flare up, if the weatherman says we're going to have a plume coming and you were good before, start your medications from before.
Right.
So you're being proactive here now. So you might want to start your nasal sprays a few days before to prepare your nose for the onslaught as well, and take your antihistamines if you have the allergies. Right. If it's not a non-allergic, just the nasal sprays alone will be useful.
Right.
And that might help to diminish the effect of the Sahara dust. It's not going to totally avoid it. If it's indoors and the dust is still coming into your house, a useful appliance might be an air filter, air purifier. Right. You can get those all over, and that might help to clean the air out in your house.
All right, Josh, we take one more. I know we run out of time. Please, just one more. Great, thanks. Great program as usual. You're very welcome. What causes these small white balls in the back of the throat? They have a very foul smell. I'm glad we took that question.
Yeah.
All right, Josh. So the ALF viewers could wait a little bit longer.
Yeah.
Tell us.
So the little, those are coming from your tonsils, right?
Yeah.
And those little white balls that you get are called tonsillets or tonsil stones.
Yeah, you can view them.
Yeah, so tonsil stones are not primarily an infective process, so you don't need antibiotics for them.
Yeah.
What they are primarily a collection of dead cells and bacteria collecting in your tonsils. Your tonsils are not smooth surfaces most of the time. They're little potholes in them. And so the dead cells slough off and it mixes with the bacteria. So when these things collect there, if you were to take them out, because some patients can take them out, they're sort of cheesy in consistency and they have that high odor because of the bacteria and the dead cells. So taking antibiotics is not going to cure it. But what causes this low-grade inflammation and the tonsil stones, a lot of times, I find a lot of patients they tend to have acid reflux problems.
Yeah.
And a lot of them may also have sinus problems and postnasal drips from allergic rhinitis. So that causes the inflammation and the sloughing off of the dead cells more frequently. So what you need to do is if you have those underlying problems, you clear up those. We treat those and we remove them, the tonsil stones. Surgery for your tonsils is not the first line treatment for that.
Okay. All right, Robin. Well, unfortunately, we've come to the end of the program. We probably were a little bit ambitious.
I know.
But we will have to bring you back on because we have a very important topic to talk about, and that is head and neck cancers.
Yes.
And we need to, perhaps whenever you're available.
Yeah, I'm sure.
Maybe if you could do it next week just to wrap it up.
Okay.
Just to give the patients some good information on head and neck cancers.
Yeah,
all right. So first of all, I want to thank you for coming on tonight. Sure. Thank you for sharing that information with the public. You gave them real practical advice.
Yeah.
Right. I know I pushed you hard through the whole program.
Yeah.
But we pushed you hard through the whole program, but you were able to still impart the knowledge in an easy to understand way, and you gave them really practical advice, and we really want to thank you for that.
My pleasure.
You're someone that most of the patients in San Fernando and the southern area kind of know you.
Yeah.
They always give you good respect and they always say very good things about your treatment with them. And I'd like to thank you as well for that.
Thank you for having me on. It was a pleasure.
Right. So one or two of the patients who were calling into Josh and they were asking for your contact details. So if you could just give the audience at home maybe some sort of way they could contact you in your ENT office.
Well, Gulvey Medical, they have about 5 numbers for Gulvey Medical.
So, yeah, that's fine. So Dr. Maharaj is based in Gulvey Medical Center in Laramie, and you can look it up online and you can call in there and you can make your appointments for him if you so wish. All right, guys. So that's it for this week. We thank Dr. Maharaj again for an excellent show. He brought it home as usual. Thank you, our viewers, for tuning in tonight. Thanks to Josh. He's here in the studio alone. He did a great production tonight, running back and forward. Thanks to those who sent in messages. And everyone, thank you very much. Have a pleasant evening. God bless. Thank you so much. We'll see you again next week. Good night, everyone.